will discuss here of course, the main lesion of the demyelinating diseases, which is MS, and we'll also show the differential diagnosis of this particular disease. In this area, or the demyelinating diseases, we have what's known as the normal brain aging, the MS, the viral and post-viral disorders, including the acute demyelinating encephalomyelitis, toxic demyelination, traumatic lesions, and the vascular lesions, including the hypoxic ischemic encephalopathy, the periventricular leukomalacia, the watershed infarction. These lesions will be discussed in the pediatric cerebrovascular stroke. Then we'll discuss the subcortical arteriosclerotic encephalopathy, the multi-infarct dementia, the CADASIL, and the vasculitis-related white matter changes. Sorry. And actually, in order to evaluate patients of MS, we need some prerequisites, which I think they are not strictly, let's say, available in every site. The patients are examined. The role of MRI have three or four parts: the diagnosis of the disease, the follow-up of the disease, assessment of complications, and the possible differential diagnosis. Then we need a strong magnet, of course. 1.5 Tesla is good. 3 Tesla may increase the sensitivity to detect more lesions. The maximum slice thickness should be the 3 millimeter. Flare images are mandatory for evaluation. Then you should know that the flare images are very insensitive for lesions in the posterior fossa. And we see the lesions in the posterior fossa more better in the T2 weighted images. The value of contrast injection in MS is debatable nowadays, and the injection of contrast material in the spine is also under discussion. And many of the literature assume that you have this technique one-stop shop, which means that you inject contrast material and you image the brain, to be followed by imaging of the spine immediately. Okay, this disease, you hear about many of the criteria and the McDonald criteria and so on, which will include these abbreviations like dissemination in space, meaning that multiple lesions in different regions of the brain. Dissemination in time means that lesions occur at different times on follow-up studies. Then the most common acquired chronic demyelinating disease is MS, and the second most common to produce neurological deficits after trauma. Usually the patients present between adolescence and the 6th decade, with a mean age about 35 years of age, with a strong predilection for females. Then the clinical presentation is very familiar to all of you, including optic neuritis, ophthalmoplegia, diplopia, trigeminal neuralgia, ataxia, sensory affection, and sometimes urine incontinence. The appearance of the lesions are also very familiar to all of you. The lesions will be hardly seen on the T1 weighted image, but easily appreciated on the T2, especially in the flare sequence. and the lesions are horizontally oriented. They are perpendicular to the wall of the finger, described in the literature as Dawson finger. And posterior fossa involvement occurs in about 10% of the cases. The enhancement with contrast is related to the activity of the lesion, and sometimes the lesions are big, mimicking a neoplasm, which is known as the tumor-effective MS, as we will mention. Then in the recent literature, they assume that the susceptibility weighted images are helpful to differentiate between bright foci occurring in the white matter periventricular area, considering the MS and the ischemic lesions. They said that the MS plaques are occurring very venular. I mean that along the axis of the vein. Then the susceptibility weighted image being capable of demonstrating blood vessels, then you can see the blood vessel and you see the plaque oriented along the course of the blood vessel. There are some issues in the literature about the use of high power magnet like 7 Tesla and so on. But actually, I know from one of radiologists in England that whenever they establish the MRI 3 Tesla in his department, many of the patients suffer from existing in this high power magnetic field. Then they are forced to remove this magnet and replace it by a 1.5 Tesla magnet that can fulfill the required criteria. But in our country, for example, there are about 30 machines of 3 Tesla MRI. All are acquired by the army, and I don't know why, but you know that whenever you feel weak, you want to be to show your strength in the side issues. Okay. Let us look at these two images. This is a 7 Tesla MRI and this is a 3 Tesla MRI. You know, the cortical lesions are one of the pathognomonic features of MS, and they are more appreciated in the 7 Tesla MRI, which is not, up to my knowledge, used in the clinical practice, at least in our area. Then on the T2 weighted images, you see multiple lesions in the periventricular white matter. The lesions are not appreciated in the T1. Some of them only show low signal intensity. But if the lesion is enhanced with contrast, then you assume that this lesion is active. And here you see many active lesions in the brain parenchyma. And some of them are a little bit larger, and they may be referred to as tube-effective MS. Black holes represents a foci of dark signal in the T1 weighted image. And the black holes are pathognomonic for persistent damage of the brain parenchyma. You know that the MS plaques are very faintly appreciated in the T1 weighted image. But if you see these lesions very clear in the T1, you know that this is a encephalomyelitic brain. I mean dead brain tissue. Then also brain atrophy is one of the criteria that should be included in the follow-up of patients with MS, because brain atrophy correlates with with the bad prognosis of the disease. You see, many patients on follow-up studies, they develop evident brain atrophic changes that should be mentioned in the report to be taken into consideration in the follow-up studies later on. And these are the what's known as the McDonald criteria, which means dissemination in space and dissemination in time. And I know that the follow-up study of a patient with MS comparing the old the previous examination to the recent one is one of the difficult tasks for the radiologist. If he is trying to produce a real report reflecting the condition of the patient. But many times we are used to look at both films very rapidly and to look that the picture is almost the same, and the easiest way for us is to write no appreciable interval changes. Unless the changes are extremely evident and you got instead of 3 lesions, 5 or 6, and you got lesions in other places in the brain, then you say that the disease is progressive. Recently, a certain society asked me to talk about the MS and the value of DICOM technology in the follow-up studies of the MS patients. Actually, we use, all of us use the DICOM technology, and we write our reports from the PACS system. And we try as much as we can to compare images, the previous one with the recent ones. But if you look for this example, and you see this is the initial scan and the follow-up scans 1 year, 2 year, and 3 year, it's easily for you to say that the disease is progressive. Then the issue of atrophic brain changes should be mentioned in the report. You see the ventricles in the initial study and the ventricles in the later on study, and there is evident development of brain atrophic changes. Actually, I know in the practice, maybe in other countries, they can use the software to compare the studies without any effort from the radiologist. But this comparison needs that both examinations should be on the same machine, the same technician, the same field of view, the starting level, the end level, and the slice thickness, which is impossible in our region. I think it's impossible in Egypt, at least. Then if you got these similar criteria, you can put the 2 examinations on the computer, then the software will start the comparison, and the result will be no change, regression, progression, and so on. Then many of the literature identify that examination of the spinal cord, and this examination showed some plaques, especially in the cervical cord. This will help to confirm your diagnosis of these lesions to be related to MS. They said that other diseases which produce plaques in the white matter do not usually cause any changes in the cervical cord. And of course, the issue of contrast enhancement is the same for the brain and the same for the spinal cord. Then MS in the spinal cord will appear as focal lesions of high signal intensity, and cord atrophy is also one of the criteria that should be mentioned in the report, similar to that occurring in the brain. One issue is that the spinal cord, the axonal loss in MS is present in absence of focal lesions. And you got symptoms related to the cervical spinal cord while the cord is free of plaques. But these plaques are on the microscopic level. They are not seen on imaging, but can be seen on autopsy. This is an issue also which indicates, is MRI of the spinal cord, the whole spinal cord, worthwhile or waste of time? This debate is still going on, and some literature say that you should include the spinal cord as a whole, the cervical and dorsal, and others say no. And there's also another debate about injection of contrast material. Some are positive and some are negative with this particular issue. Then we have atypical presentations of MS, including the tumefactive demyelinating disease, the Bell's concentric sclerosis, and the primary progressive MS. The tumefactive demyelinating disease is a type of MS where the lesions are big, and these lesions will show marginal enhancement, which is known as characteristically incomplete ring marginal enhancement. These lesions will be surrounded by perifocal brain edema, and they are sometimes exerting a mass effect similar to the tumors occurring in the brain. But the fact that the lesion will show incomplete ring marginal enhancement helps you to spot the diagnosis of tumefactive MS, which is known also as Marburg variety of MS. The enhancing edge will show diffusion restriction, while the core of the lesion will not show diffusion restriction. Another type of MS is known as the Bell's concentric sclerosis, and from its name you got concentric rings inside the lesion, and these rings may show some contrast enhancement. They may be surrounded by brain edema, and the margin may show restricted diffusion. This is the appearance. This lesion is, not frequently seen, but it's not uncommon. It is not uncommon to see this lesion in the clinical practice. And many times, if MS is not in your head, then you may proceed to diagnose other possibilities which are far away from the real diagnosis. If you reject the contrast material, you got faint marginal enhancement of the rings. And on diffusion weighted images, you got restricted diffusion, as you can see. Primary progressive MS is a progressive disease which has a rapid course over 1 year. And this will include dissemination in space and the dissemination on time. Then the lesions are similar to those of MS, but the progression of the disease is rapid. Then we have lesions or diseases that can produce plaques or abnormalities in the periventricular white matter and should be differentiated from the MS. Number one is the subcortical arteriosclerotic encephalopathy, prominent Virchow-Robbins spaces, acute disseminated encephalomyelitis, neuromyelitis optica, and the CADASIL, which is cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. This is the abbreviation CADASIL. Then what's known as unidentified bright objects, or UBO. Normal brain imaging is the brain of an adult old patient with some atrophic changes and abnormal high signal intensity lesions in the white matter, periventricular white matter. These lesions are seen in healthy patients, and they are not referred to as a disease. They refer to as normal brain aging. But actually, if you did so in the report, many will attack you. Let's look to the susceptibility weighted image and see the difference between the MS plaques and the ischemic foci. Ischemic foci has no relation to the venules, and ischemic foci are a little bit far away from the ventricular wall. They are not perpendicularly oriented to the ventricle, and the MS, as you can see, are perpendicular, and they are surrounding the venule itself. This idea supports the value of susceptibility weighted images in differentiating these two cases whenever there is some overlap between both. Then normally in old patients, you got many old infarctions in the white matter, and this is due to subcortical arteriosclerosis, which is commonly seen in hypertensive and diabetic patients. And in my opinion, these lesions are not referred to as pathology. They are referred to usually as the normal brain aging. Then the perivascular spaces, or known as Virchow-Robin spaces, are the CSF space accompanying the penetrating vessel through the brain substance. And if you cut this horizontally, then you got many foci in the white matter that are filled with CSF, showing low signal in the T1 and high signal in the T2. These foci are usually smaller than this, but many times you got abnormal enlargement of the Virchow-Robin spaces, which is considered sometimes as a normal variant, and sometimes are related to some diseases like the Canavan disease, which affects the Virchow-Robin spaces. Then acute demyelinating encephalomyelitis is not an inflammatory disease. It is a demyelinating disease. In the old lectures that were presented by me many years ago, I included Adam in the lecture of inflammatory and infectious brain diseases, but actually this is a demyelinating disease in response to an inflammatory insult, not necessarily to be in the brain. Then it's an autoimmune phenomenon. It has a similar appearance, almost, not exactly, but may also present by clinical features similar to MS. One of the differentiating points is the presence of viral illness or recent vaccination within 2 weeks of the disease onset. You got multiple periventricular high signal foci in T2 and in the FLAIR images. These lesions will not show diffusion restriction, and they will not show enhancement in many cases. This is an appearance, got many lesions, and characteristically these lesions are big and they are of variable size compared to those of MS. Some of the lesions are located in the cortex of the brain, others are located in the white matter. On the CT, you appreciate few lesions compared to MRI. On the FLAIR image, you can see the lesions too many compared to those seen in the CT scan. And this is the diffusion weighted image. And according to the literature, ADAM lesions will not show diffusion restriction. And I will show some of the lesions that are stated in the literature. They do not show diffusion restriction, but in many cases presented on the internet, they show diffusion restriction. And the explanation for this depends on the lesions, whether they are acute or they are relatively chronic. In acute lesions, you suspect that these lesions will show some diffusion restriction, but in relatively old lesions, you will not see this diffusion restriction. And this is a comparison between ADAM and MS. Multiple sclerosis are relatively smaller plaques. They are more symmetric. They involve the subcortical white matter. They commonly involve the posterior fossa, and there is a relapsing and remitting course, although the recent literature say that the MS may have a relapsing and remitting course. Then we came to the neuromyelitis optica. This is another autoimmune disease, and this disease is more common in females, and it affects the optic nerve and the spinal cord, and sometimes the brain. The lesions are different from those of MS, and affection of the optic nerve is a prominent feature of this disease. This is a comparison between the plaques of neuromyelitis optica, which are big and central, while the MS plaques are small and peripheral. This can be easily evaluated in the axial T2 weighted images of the spinal cord. I am personally feel that the axial T2 of the spinal cord is more better than the sagittal images for evaluation of the plaques inside the spinal cord. Neuromyelitis optica acute episodes are very severe, and if untreated will lead to severe irreversible effect. The patient with neuromyelitis optica may have other autoimmune diseases, especially the Sjögren's syndrome. And this is a child, 6 years old, with neuromyelitis optica. Of course, this age is not the age of MS. And you got enhancement of the optic nerve on the left side. You get a very big central lesion inside the spinal cord, and patchy high signal intensity in the brain parenchyma, not fitting with the appearance of MS plaques. Then CADASIL is an autosomal dominant vascular dementia. This disease results in extensive white matter ischemic changes, and these ischemic changes occur at a relatively younger age compared to the subcortical arteriosclerotic encephalopathy. And another differentiating point, which is very important, is the affection of the temporal lobes, which does not occur in subcortical arteriosclerotic encephalopathy until very late. Then you see a CADASIL lesion. The patients are usually younger, let us say 45, 50 years old, with prominent involvement of the temporal lobes and, of course, the periventricular white matter. Then we came to a major problem in the current days. Many times, many of you, whenever they are interpreting MRI images of the brain, then they identify a lesion like this one. And the patient is not complaining of anything. Let us say he has she has some headache or other minor symptoms. Then the report will say that there is a bright focus in the white matter and no edema, no mass effect. Then at the conclusion, they said that this may be ischemic or maybe a demyelinating focus for neurophysiologic studies. Actually, there is an entity in the current literature which is known as unidentified bright objects. This means that in a patient who is not actually complaining of neurologic deficits, you may be confronted by 1 or 2 or 3 lesions in the white matter showing this appearance. And the literature says that this lesion may represent an ischemic focus, may represent a dilated Virchow-Robbins space, may represent a demyelinating lesion, and sometimes patients with headache of, let us say, long-standing headache, they develop multiple foci in the white matter, which are known as headache-related. Then these are the suspected reasons in the literature: hypertension, smoking, diabetes, migraine, and heart disease. They are not usually related to MS. And these patients should not be investigated for the possibility of MS, in my opinion. Then the site of the lesions may be in the basal ganglia, in the brain parenchyma, brainstem, cerebellum, and the salami. Of course, these lesions will not show diffusion restriction, and they will show normal MR spectroscopic findings. These are examples of unidentified bright objects, and the lesions are not showing diffusion restriction.